So this is a concept map. I did not create this. It was created by Maggie Roth. I found it on Pinterest, but it probably summarizes what I was talking about quite succinctly. So there's two types of pancreatitis, as I mentioned, the acute and the chronic. In both cases, alcohol abuse, obstructions like the gallstones lead to this condition. What happens in acute pancreatitis is because of the blockage, there's a buildup of those digestive enzymes, and once they're activated, they can cause autodigestion, the pancreatic injury, the inflammatory response. Some of the complications are it can lead to cell death and leaving the patient vulnerable to infection, can also lead to different organ failure. Since pancreatitis affects other organs like the circulatory, respiratory system, as well as the kidneys, therefore, they can lead to a multi-system or a multi-organ affecting multi-organs, and therefore another thing is that to look for dehydration, signs of dehydration, and it's this collection, the edema, the collection in the pseudocyst formation. Sometimes the pseudocyst will burst, and that would again leave the patient vulnerable to that internal bleeding and infection. Symptoms, of course, the patient will report the severe abdominal pain, and treatments is IV fluid, aggressive IV fluid, in fact, to address the dehydration and restore that plasma volume, and then pain medication for that severe pain. Some of the labs that are markers, as I mentioned, as the lipase and the amylase. Chronic pancreatitis again manifests itself as the abdominal pain, but also that malnourishment because of malabsorption. There's not enough digestive enzymes to break down the food and facilitate absorption of the nutrients, and therefore there's severe weight loss. And over time, the pancreatic tissue and the cells are destroyed, and that leads to the destruction of the functionality of the pancreas, and this is irreversible. This loss of functionality is irreversible. Pain, the pain is pretty severe, needs pain management. Sometimes the only option is surgically removing all the dead tissue. Long term is changes in lifestyle, especially diet. Low fat diet, they can no longer digest fat. All of the fat gets excreted and might exacerbate the condition. So therefore, that's necessary. So the nursing diagnosis is acute pain, and then that's related to that obstruction of those pancreatic bile ducts, and the evidence is the reporting of pain by the patient and the behaviors like the grimacing, etc. And the pain could be either sudden or a slow build-up of very intense pain because of the blockage leading to that tissue damage. Chronic pancreatitis leaves the patient at risk for imbalanced nutrition because of that malabsorption and malnourishment. There is severe vomiting, there's a loss of digestive enzymes, and therefore food is not getting digested. Loss of insulin means uncontrolled blood sugar and therefore diabetes, weight loss, There's not enough nourishment, therefore loss of muscle tone, mobility. The food intake is inadequate to keep the body nourished. So some of the interventions are, again, checking the vital signs, checking for fever, hypertension, managing pain, whether it's through opioid or non-opioid methods, placing them in the patients in a semi-Fowler's so as to reduce that pressure on the abdomen and give them some comfort from that discomfort that they're feeling. Monitoring labs, especially the lipase and the amylase. Amylase returns to normal after treatment. Lipase stays elevated for a longer period of time. C-reactive protein basically is a sign that indicates the organ failure, inflammation, and so they are elevated. WBC hematocrit again indicates disease infection. Glucose is hypoglycemia because of the lack of insulin, so it requires that the patient must take insulin to control blood sugar. And then, as I said, because there's no the pancreatic juice to balance out the HCl from the stomach contents. Therefore, in order to avoid the formation of ulcer, Tagamet should be given to counter this excessive acid, and prevent peptic ulcer. Antibiotics if there's an infection. Monitoring the kind of foods that the patient is taking, and patient education. So among that patient education is that till the illness is resolved, the acute phase, they are, in order not to aggravate their condition, and they are NPO, they're not nothing by mouth. When it does get resolved, the inflammation, they can go on a clear liquid diet for a few days. And if they are severely malnourished, they require parenteral nutrition. Fluid and electrolyte balance is important, especially to check for signs of dehydration. Again, checking their mucous membrane for signs of dehydration, and their input and output. Patients should be encouraged to take in enough fluid, and if their renal function is unimpaired, then the output should indicate that. Aggressive IV hydration is required. Lifestyle changes, they should be counseled on. Not drinking alcohol, stop smoking, healthy diet, low fat, and then drinking enough water throughout the day to remain hydrated. So basically, again, following orders, medication adherence, the counseling for diet, healthy lifestyle, and hopefully finding ways to elevate mood, reduce stress, etc. So that is it for this topic.